Hello, everyone who have joined yet, and we're just waiting for a few people so we can start our webinar. Thank you for joining in. Me, Dr. Numan, and Dr. Artem are here. So I think we'll just begin, and I'll just give a quick introduction of Aculiners. We are doing this for a long time, and we want to launch this in Middle East. And we'll be talking about some case selection topics here. Just want to give a brief introduction of the product itself. So Aculiners is a medical device company, and it's certified ISO 1348. This is very important for any company, for a medical device company. And that's why we have introduced a multi-layered material for our aligners, which are near invisible trays. It is a unique tri-layer system, which helps to reduce 40% of the initial force. So, whenever you introduce this appliance to the patient always complains there's always tightness, and this will reduce and help, the discomfort, because it is something new, and you don't know how you're going to react with. And plus, it has a dual shell, hardness around it, which helps, even you can recommend for people who have light bruxism also. And it gives an additional, rebound effect that I'll show you with other. So it's a rebound effect. It is because of its tri-layer that it gives the cushion effect. So it absorbs the energy and it rebounds back. So this is a very good example of this, that it flexes and comes back. So this, keeps the force for more than it, the elasticity there. So it gives it 10 days more for, for the wear to effect. So we are CE certified, and we have a lot of expert orthodontists, as you're seeing Dr. Artem here also. And we would do our treatment plans within 12 to 48 hours. And our manufacturing is 3 to 4 days. That is not included is the shipping. But we will ship as soon as possible with the courier service that is assigned. So back to now Dr. Artem here, and he will start his presentation.
Yeah, hi everyone. Yeah, let me just while I'm turning on my screen. Okay. Actually, we're ready to start our next webinar in a series, let's say. And let me just, okay, I will share this one. Yeah, I hope now you can see my screen with Aculiners. And while we are starting, one thing I wanted to add about the tri-layer material, because like you said, it's very nice for the comfort of the patient. It's one thing, but what we also know clinically, and what we all should remember, is the very approach of orthodontics is constant light forces. And with this kind of material, we are approaching this, and we have these forces, distributed quite equally if we compare it to the old material. But okay, it's not our today's topic. It's just something I wanted to to also to mention. Okay, and again, welcome everyone. And today we will speak about about two topics. And every time I want to give as many, insights, as many details as possible. But every time I start these kind of meetings with saying that I don't know who you are. I mean, what kind of experience you have. I mean, if you are starting with aligners, experience with brackets, young orthodontist, that's why I will probably try to show you how, well, some steps in my career, in my approach, and make them useful for you. And hopefully you will finish this webinar with some ideas that might be new for you, but the ones that you can use immediately in your practice. Speaking about case selection, that's a very interesting question, because that's how I started, and many of my colleagues started with aligners. Is that normally aligners being kind of new, still we still call it a new technology. We have normally good experience with braces. And when the patient comes to your office and you want to start with aligners, very often our colleagues come with a problem like, okay, do I take it for aligners? Or, okay, I know how to do it with braces, but what about aligners? And sometimes it can be very tricky. And speaking about case selection, I should start with the learning curve. Probably the scheme, it can be presented differently. The basic idea is that when you start something, when you are, say, at the lower left point, when you have little or no experience, of course, it takes some time. I mean, it's very obvious. And it's not only speaking about, aligners, orthodontics, or it's about anything new that you are learning. And I think it's also very common and very obvious idea is that you get some experience, you do your training or you do your practice, and then you get better. Well, that's obvious. But why I'm showing you this scheme and reminding you of this learning curve? Two ideas. So the first one is more, let's say, motivational. As you can see in the very beginning, when you do something and you're not that confident and you get some experience and still you can't say for sure, okay, that you know how to do that 100%. And after some time, with several, especially with orthodontics, it takes some time, it's some period of time. Then you have a very, quick, let's say, giant leap. And then all of a sudden you look back and you say, oh, wow, I have done so many things and now I feel confident. That's more of a motivational point. So if you do something and you don't get the results immediately, it's okay. But the second point is that normally when we speak about starting something new, about, let's say, starting aligners, very often we hear that start simple, like start with simple cases. Take some, not skeletal cases, not for orthodontic cases, have some, let's say, crowding, mild crowding, and then, do your cases, see how the system works, see how aligners work, how your provider work, and what you can do with this one. That's also very, let's say, very a sensible approach. But like I told you, I'm going to share my experience, and I can tell you that it can be different. Because when I started with aligners, it was the aligner clinic. And when I was a young orthodontist and I came there, it was not a question of how should I select the case. It's like you have the patient who came here specifically for aligners, and you have to treat him or her with aligners. And I was really stressed but it was very, for me, it was very beneficial. We can kind of discuss that. I will tell you my approach, because in the end, when I, for example, give you the photos, okay, this one is a simple case, start with this one. Okay, you will have some kind of reference, but can you put this photo outside your clinic so the patients can see this and they say, okay, oh yeah, I can go here, or no, I'm too complicated, I will go to another clinic? Of course, no, you won't do this. You can't filter the patients like that. That's why the approach, when you not always start simple, can also work. We will speak about that. Okay, we started speaking about crowding, and let's focus on this this problem. And of course, we have let's say different cases of crowding, from mild, average to severe. And when I show you the pictures, sorry, I can't see the chat right now, but you can text there. Can you take this patient for aligners? Speaking only about crowding. Well, probably you say yes, or you say plus. Okay, what about this one? Can you? Or better, can you have it as your first patient for aligners? Okay, what about the lower jaw, like this kind of crowding? Or this one? Or like this one? Okay, if you want me to answer, of course, you can treat all these cases of crowding with aligners with not too many problems, and all these patients were actually treated with aligners. But we're speaking about, back to learning curve and case selection. Let's have a look at this one. I came up with some examples. Actually, this one may look really, really nice. What crowding are you talking about, doctor? Yeah, but there are some mild derotations, let's say. We want to get some space for the frontal teeth. And okay, we can have it at this case and say it's a very mild case. It's less than 4 millimeters of crowding. But the next step you should think of is, what can you do about it? And I put an example here. So we can always think about getting the space for the teeth with expansion, with proclining the incisors, let's say, and some IPR. Okay, and so it seems like a very, very nice and easy case to start with. And you can see it also with the little bit of vertically, or let's say even retroclined incisors. And it's very obvious that is what we can do about it to get the space. Also, the canine is a little bit more vertical than probably we would like to see it here. And if we look at the treatment design or clean check, the treatment plan, well, it's quite obvious that's what we do. We have a little bit of derotations, proclination. Okay, the canine is more derotated, as you can see, but that's it. Again, the question is, will you have such many such patients in your practice? I don't know how it works, for example, in your clinic, in your country, but very often the patients who are like these, they just don't come for treatment at all. Okay, so that's it. But that can be an example, probably an ideal example to start with, because everyone will be happy and it won't take a lot of time. If we look at this one, at this patient, this is more complicated. That's why I put it here as like moderate case, up to 8 millimeters of crowding. We are still speaking about this problem. And again, the next step is to think how we can treat the case. Well, here specifically, how do we get the space? We still have the same expansion. If we need to procline the teeth, okay, but we can think, and we should think, three-dimensional distalization. Yeah, it's like a very common approach in orthodontics. If we don't have space, we do this. Let's have a look at this case. Yeah, the expansion is definitely needed, especially you see the premolar. But what I wanted to also to show you is a small trick that many orthodontists already know, especially those who work with the aligners. Look at the molar and how it's rotated. I would say, okay, I can't say like 100%, but in many cases, the derotation, this mesial out derotation, is very beneficial, and that's one of the first things you do in your planning, because simply because of the anatomy of the molar, normal anatomy. If it's a little bit palatally rotated, it takes more space. Once you derotate that, you kind of and if you even don't even add any expansion, it gives you some space. It's enough here for the premolar to come back. If you look at the other side here, okay, don't pay attention to the filling. It's not very good. I mean, the occlusal surface. But here, it's not that rotated, and we do simply a little bit of expansion. So my basic idea is that, and I will repeat that, and we will come to that, is it's not about the complexity of the case, really. It's about you knowing what to do in this case. When I say you, it's both you as a doctor, as a clinical, and also the clinical expert at the side of the company, because they can go come up with these small hints, small things that you probably don't know, and probably you shouldn't even know about that. But it's another story. I will tell you my approach to that as well. Okay, so these are some examples when we have the STO, the scan model, and the photos of a patient with crowding, and how we deal with that with the aligners, like before and after. Again, okay, good case selection. Thank you, doctor, you can say. But if we go this way. This one is really a complex case because we have some teeth blocked. It's more than 8 millimeters of space crowding, but we still think about what we do. Of course, we have discussed distalization. Probably here we will need TADs to distalize. Maybe we should think about extraction. Of course, all these things come and you think of them during the diagnostics about what you need to do. Looking at this case in CleanCheck, as you can see, some teeth are proclined, and actually we need to retrocline them. On the other hand, the lateral is blocked palatally. It's another side here. But we still have the same things in mind. Okay, because every time we say complex case, we should understand that a complex case is a collection of simple cases. I hope it's you understand what I mean. Is that we started with expansion and proclination, then we gradually add some approaches, and we go pretty well with the complex case. When we speak about distalization, by the way, of course, in this case, it's a class 2 patient, and when we distalize the upper jaw, we also work in the anterior posterior plane. But because we're speaking about crowding, I'm focusing on this one. But of course, we understand that these things are interconnected. We speak about the class of occlusion, but we also speak about the crowding. We distalize, we get the first class occlusion, but also we have the space for the crowding correction. Okay, I think it's just something that should be kind of obvious. These are some examples. By the way, this I think this one was coming from Dr. Barry Glazier, but I just wanted to show you that use this case to get back to the story I wanted to tell you about one of my first patients. This one seems quite easy. It's first class. Probably the most difficult part is apart from just crowding, is the rotated canines on the upper jaw. And what I wanted to share with you is this. Okay, when I was getting ready for the for this webinar, I actually remembered two things that I wanted to share specifically. The first one is that when you start and when you need some kind of let's say a roadmap, many doctors, they don't have it, because we have our medical, let's say, diagnostic documents, datas, and they are very general. But when we switch to, let's say, aligners, we don't have like a, or we didn't have back then a very convenient scheme to use. This one, which I was proposed by one of my colleagues, I used a lot during my first years. Have a look how it works. When I have the patient, when I have some problems I want to resolve, I specifically focus on what I want to do. It's not much. But when I speak about space analysis, which is in case of crowding, of course, we need to address first, I can use, for example, expansion. I say, okay, I want to expand. Good. Do I need to procline? Yes. Okay, I will procline in this case. Am I okay with IPR? Yes, I'm okay with IPR. I need it probably for some other reasons. That's it. Extraction, for example, no. I understand that in this case, I don't want extraction. We don't speak about aesthetics today too much. It's another topic, but also something to consider. And speaking about stability, it's mostly about how much you expand and how stable you want the results to be. For example, in this case, we wanted to keep the intercanine distance, but I wanted to expand in premolars or premolars region up to 3 millimeters, let's say 1.5 each side. Why did I use this structure? Well, firstly, it was very helpful for me to analyze the case, looking at the photos. But also, as you can see, I put a screenshot here, how I used to communicate with technicians, with designers, because now today and with AccuAligners, the treatment plan is a little bit different. I mean, it's more convenient, it's more detailed, but back then, all we had was the window where we just, okay, dear technician, please do this, please do that. Okay, they were reading that, and we had to deal with this one. And that's what we did. As you can see, that's exactly what I got from my table. Okay, how I want to expand. Do I use IPR? Yes. So, and proclination, I just put them which teeth I would like to procline, retrocline, which use as a reference, and that's it. And then getting the clean check and getting the results. We will speak about this picture of canines a little bit later in the second part of our today's meeting, because there is something to discuss. And getting some really great results, yeah, why not? Okay, another thing, yeah, before we get to the next slide, another thing I wanted to share with you is my experience from totally different sphere. It's from language learning. English, it's not my native language, okay? So, but when you learn a language, and I was talking to my tutor, to my teacher back then, and she told me a very, very funny, I would say, thing, that when an adult starts learning something, you know, think about learning curve, and normally how they teach the language, they say, okay, language, any language is for communication, it's for speaking. That's why very often when you learn the language, you go with, okay, today we will speak about your dog, I know your favorite color, how many brothers do you have, and that's it. And you gradually go with some, you know, some more details. But then she said, some people, actually many students, they come up to understanding that, wow, English, there are so many grammatical tenses, like present perfect, past continuous, whatever. And what they do, they come to the teacher and say, teacher, please give me the table. Give me the table where you have the past, present, future, simple, continuous. I will learn the table and I will be happy. I will speak English. And what she told me is, it's a mistake. I said, why? I mean, if you have the reference, you can learn that, you can use that. Okay, her idea was that it's not like this. Remember, she said, remember your native language, the one that you speak from your childhood, and how you learned that. Did you start with the grammar, with the tenses, with, this? No, you just did it. You just practiced, you had the communication, and later, during your school years, you came to learn the grammar, to have the tables, or all these things. And these tables were more like a reference for you. Yeah, you already know how to use it, but something to look at. Oh yeah, that's good. I'm doing it correctly. So it's a little bit different approach. So when somebody, back to our topic, asks me or my colleagues, okay, show me which cases I should use, you can come up to this one with experience. We can share the tables. And when I was asked to speak about case selection, I thought about some cases. I thought about my story, but I didn't have any, let's say, tables to follow, any rules to follow to choose this or that. Luckily, our colleagues already did it. And I'm going to share with you this one. You can take a photo, take a picture of that. We were speaking about crowding, and if you have this book, yeah. If not, okay. So I will say hello to Sandra next time we meet, because she did a very great job. As you can see here, we have the colors, which is light blue. We will say mild or simple case with crowding. And again, back to what I was saying, what we should do in this case: expansion, proclination, IPR. When we go to a moderate one, we have some more options. The gray one is a severe case when we can speak about extractions and so on and so forth. So maybe if you need this one, okay, have it as a reference table. But what I'm saying is that you can't always get the patients according to this table only. Yeah, you can't say you are a blue patient, come up to me. You are dark blue, see you in a year. No, but okay, if you need this one, have a look. I also got the same idea of case selection or case categories for some other problems. For the vertical, for example, problems with deep bite or open bite, which you can use at least again as a reference. So take a picture if you want. We're not speaking about specific anomalies today. It's more as a reference. With transfers problems, yes, also it depends on the case. If you want to start simple, like we said, look at the light blue ones. And of course, anterior posterior, when we speak about the classes, it also can be of different of different difficulty, let's say. So simple, moderate, and advanced. Yeah, it can get, as you can see, the scheme can get more complicated if we speak about growing, non-growing patients. It's a separate topic. Probably if you're interested, let me know, because if you want to speak about this one, we will. It's not a problem, because these topics we are discussing today were actually suggested by you last time, so that's why we are talking about that. Okay. So these are some schemes if you want. I promised to tell you my story about my, let's say, first case, and actually it very much correlates with what is written Barry in his book. One of our, another orthodontist with aligners. What happened again? Remember, my first experience with aligners was in a aligner clinic, and one of my first cases was with a lady with a very severe crowding, like we said, more than 8 millimeters of crowding. I couldn't tell her that I'm not experienced. Oh, sorry, I need like a simple case to start with. No, for me it was like do or die situation. I ended up with a case with extraction, and it was an extraction of lower lateral incisor. Well, how the lady agreed upon that, that's a whole different story. How I agreed on that, that's what was important, because for me it was, wow, it's like a severe case. I could be very doubtful treating it on braces even. I would have thought a lot about it. But okay, I took the aligners, we agreed with the extraction. Of course, I was lucky enough with the technicians. We had very good support back then. We got with the nice treatment plan, which wasn't long. Actually, it was quite short. Thinking about that now, probably I would have changed the treatment with more distalizing, maybe extracting the premolars if needed. Well, actually, I think now that I should have put the photos of this case in the presentation. I forgot to do this. Okay. Anyway, the basic idea now, not about how well she was treated and how she was happy, how I was happy, but actually we were all happy about that. But my point is that I started with a quite difficult case for me as a young orthodontist. But what happened? After that, every next patient for me was like, oh, come on, look at my first patient lady. We did it, and everything worked fine. And suddenly, very quickly, I can say I jumped through this learning curve in terms of confidence, not in terms of experience. Of course, I still had to learn a lot. And like I tell you now, I'm telling you now, I would have changed a lot of things. But the thing that I did a case which was quite difficult with the aligners, and everything was, let's say, okay, gave me a lot of confidence. I'm telling you that because, and I'm in conclusion, we will speak about it a little bit more, is that it's another approach, because sometimes depending on your, I don't know, temperament, about your character, if you start simple, it's okay, but you should be ready one day to make the next step, to make like a moderate case, and then to go to advanced case. If you know you can do that, perfect. It's the ideal way. And if you have the patience like this, that's perfect. If not, sometimes you can jump, and this leap, this jump can help you to get more confident with your treatment quicker. Of course, the very important part is your partner at the other side. I mean, the aligner provider company. And we will speak about it probably during the next part, because another thing that you were asking about is the attachments. That's interesting, because very often today when we speak about aligners, the first thing that we think of is the attachments. It's like they go hand in hand. But interestingly enough, it was also a long story. It was a long story, and maybe if you had experienced some 10 years ago or even more, there were very different approaches. And I can tell you, it was with the approach that we don't need any attachments. We don't need any attachments. Well, probably the problem was that they couldn't make any attachments. But some companies, they said, okay, the aligners will work without any attachments. Then with experience, oh no, we need some attachments. Okay, they started with a normally vertical, horizontal attachments, and that's it. Then, it was the other extremity, like we need attachments to all the teeth. Think braces. Yeah, you put the braces on each tooth, attachments should be there as well, and so on and so forth. It was very very changing situation, depending on the experience, depending on the company, with with some specific shapes of attachments, with different like double attachments, with the optimized attachment, and so on and so forth. So the good thing is that with experience, we had the data, we had the knowledge, and both within the company, we had our let's say researches and tests, both in vitro and in vivo, and also our colleagues like Dr. Bauman, and I think there was a very nice article by Tommaso Castroflorio. He's an Italian orthodontist, and they made a very interesting computer model of teeth movements with crowns and with roots, depending on which type and how many attachments we use on the tooth or on the anchorage unit, and what forces we actually have. And that's really great. And I mean, I was really happy that it wasn't just, a tool that we have, but it was a tool that is being analyzed, that is being somehow changed and, let's say, optimized in a way how we use it. Well, I gave you some, just some examples of articles that were very interesting for me to read. But then again, I totally understand that maybe not all the doctors are interested in this, technical part, in this more physical than clinical part of, forces, of the vectors, of the moments of force. And thinking of that, I totally understand, and it's okay. And it's okay. You should understand that probably, again, speaking about the ideal approach for the doctor, maybe I don't want to think of that. Why should I think about, what kind of attachments and why you put here and there? All I want to do is I get the patient, I do the diagnostics, I do the treatment planning. Yeah, I know what I need to get in the end and how I get it. Should I think about, what kind of plastic you use? Should I think about, what is the size of the attachment and, the surface of the attachment you use for the movement that I want to get? I have no answer for that. Because, actually, I have the answer that it's different for every doctor. What I came up with some time ago with another company, the aligner companies, they have this kind of certification courses for the doctors to start working with them. And one of them was speaking about the clean check, and they had a whole part of the lecture with the points for the doctors, how to check the clean check, let's say. And they said, don't you ever admit or approve the case when you got the first clean check. Never do that, they said. And I said, why? And I said, no, because the technicians, they are not about medical knowledge. They just put, this or that. That's why you check this point. You check this one, starting with how the jaws are oriented in the clean check according to the probably the pupils, the eye line, and ending with every teeth and every attachment. If you are interested in this, if you have time for that, okay, that's nice. But for many doctors, and sometimes for me included, when I have like many patients a day, all I want to do is to have a good working clean check based on my clinical preferences. Again, I'm happy that today we have more and more companies, and I have more and more experience who understand that it's important. And that's why I'm here with you with EquiAligners, because I know that people there, they know how it works. And not only I have to recheck and to tell them, oh, it's not like that. No, sometimes they can come to me and say, dear doctor, this one should be done this one, or this movement will work like this. And I say, oh yeah, thanks for mentioning this to me, or I don't even have to think of that. But speaking about attachments, okay, so it's the sound. have a look at some of the clean checks I get from the company. And now, again, speaking about the attachments, what are your ideas? Okay, again, I'm not seeing the chat. I'm not seeing the chat. Sorry, I will look through it probably later after the presentation. But maybe you have noticed something interesting. Maybe you have some questions. Again, let's focus on the topic we are discussing, the attachments. Okay, I will show you another example, another case. Please pay close attention to the topic, to the attachments. Okay, maybe something unusual or something that is, well, that initiates questions from your side. Okay, again, I don't know what you are typing there, but probably I can guess the questions that you can ask, or the comments that you make. Probably about the type of attachments, yeah, and maybe the number of attachments. Maybe somebody of you is saying, okay, too many attachments or something like that one. Yeah, maybe, I don't know, maybe not. Have a look at this one. No attachments, right? Okay, so let me tell you what I see here. Firstly, like we started from the with attachments topic, we said that there were very many different approaches. Like we need attachments, we need no attachments, we need very specific ones. Again, the very sensible and very obvious idea is that sometimes we need attachments, sometimes no. Because if we think about attachment, is very simply, it's an object that helps us to expand the surface of a tooth for the aligner to give the force to that. Okay, so what it means, on the one hand, it means that if we have a surface like in the last case I showed, when we, let's say, derotate, we procline, expand the teeth, speaking about incisors, for example, the surface of that. Do you need any attachments to procline the teeth? No. Why? And I promised to tell you about the canines in one of the case. I remember with crowding, where there were very well, there was the rotation about I think about 45 degrees. what the doctor did and what we did, we didn't use any attachments for these teeth. Why? Because in this case of this lady, the surface of the canines was very wide, and all you had to do is the couple of forces you do to rotate the canine, like from buccal side, let's say this way, and from the palatal side that way, and we get the rotation without any attachments at all. That's on the one hand. On the other, and you saw it in the last case. Yeah, there were some buttons and the cuts for the class 2 elastics for the bite jump. But okay, that's another story. But on the other hand, and I think we discussed it with you at our previous webinar, some movements, well, think extrusion, yeah, it can't go without attachments. So the basic idea that there is logic, physical logic and clinical logic behind every approach. It's about the number of attachments and if we need them or not in this or that situation. What about the shape of attachments? Another case. If you haven't noticed it yet, the attachments, they look the same. Okay, so maybe I should pause here for a second. Speaking about the shape of attachments, as you can see, and again, if you're interested, we can have a separate meeting discussing the physics of that. But here it's like a beveled cylinder, and that's it. Maybe you got used and maybe you saw different approaches. Okay, here we need like this like a moon attachment, or here we use like a double crescent attachment, or here we will need like a square attachment or a round one. Well, again, the basic idea is that we need to apply the force to the tooth to move into the direction that we need, and that's it. And thanks to the lab I'm working with these days with AccuAligners, they came up after all these researches and tests with a very nice model of the attachments of this shape. They look the same. Of course, they can be a little bit differently, sized, and depending on the movement, they are placed with the bevel to the side that we need. You see, I'm quite emotional about that, just because it was really interesting to see how it all worked, how it all developed with all these tests, and understanding that why when you say we need two attachments, but actually physically it's just one attachment, but with different surfaces, put in the different directions. Why should you? Okay, very often, what I'm trying to say that very often, what I saw in these years is even using the attachments for more like a commercial tool, saying, "Oh, now we came up with the best attachments possible." Oh no, next year they say, no, it wasn't that. Now we have the best attachments possible. And you as a doctor, like, oh, mine, like, what should I do? From this point of view, probably it's a good idea to learn some basic things or to refresh some basic things on the attachments. On the other hand, again, if we know the company is good, we trust the company. For me, I don't care what kind of, on what shape, what of attachments I have to fix. But another benefit, probably, which is not obvious, is that it made the technicians' work more predictable and easier. Because when you have the two types of attachments that work, and you just have to apply it correctly, you have less space for mistakes, and that's really good. That's one thing to think about, and that's what I see in the results as well. This one I just showed you. Why? Because again, it has some additional things with buttons and cutouts. The attachments we have discussed, but also some attachments, let's say, are blue and some of them are white. Maybe it's a stupid question. Maybe you can quickly understand what it is. You can text that, but I wouldn't have asked about that if some time ago my colleagues hadn't asked me about that. When I showed them the ClinCheck, they said, "Oh wow, why some attachments are these and some of that in color?" But yes, I think you understand that, or maybe you even texted that. Of course, they are. This is a refinement, yeah, and the scan is with old attachments, and if needed, new attachments are added on the other teeth. It's just the way, the approach we have with the refinements, for example. Speaking about attachments, also maybe some things that you have noticed is these as well. Yeah, I mean, this is how you see the, let's say, bite ramps, yeah, for additional disocclusion. It's not an attachment, yeah, it's some thing like on the liner, quite obvious. And maybe you notice this one, yeah, it's the so-called negative attachment. Yeah, this is the additional point of pressure in the liner, which we apply to the tooth. The same thing like power ridges. Yeah, the power ridges is also there if you need them to control the torque when you move the incisors, let's say, palatally. I mean, it doesn't mean that now we go only with cylinder attachments and they work. No, of course, everything is common sense. If they work for most of the movements, great. If we need something extra, here it is. So my basic idea about attachments and how I approach them now is this. Okay, again, maybe it's too obvious, but we have so many questions that, of course, attachments must have for specific movements. It's obvious. It's physics. But at the same time, when you can simplify without losing the quality, do this. It's not for all the movements. Yeah, we have discussed that. We have seen that already. If we can use the universal type of attachment like here and it works, why not? At least for the technicians, for the technical part, less mistakes. And that's why a very important thing is to learn your provider. I mean, from the technical part, why they use these attachments. Do they have any logic, any protocols, any improvements behind that? I'm happy to say that with EquiAligners, it works exactly like that. And that's what I see with my patients working with these kind of attachments. I know if there is one, I need it. If there isn't one, probably the teeth or the movement is from the second part. Not all movements need the attachments. Okay, again, it's a topic. It's more like very general topic of attachments. If we want, if you need some more in-depth thing, we can do that. Like I told you, there are two types of doctors. Yeah, those who want to know all the elements, all the things, maybe because they don't trust the provider. Okay, and another part that thinks, okay, I don't need to know about that. Come on, just give me a good tool that works. Why not? So it's just, I can't say that this or that thing is right or not right. Once you, I don't know, when you buy a new car and you test drive that, and when you push the pedal and it works like this and you like that, that's good. You shouldn't think about, okay, I don't know what kind of engine and what happens in there. If you know that every time you go into your car, you start the engine, you push the pedal, and you have the same result, the same speed, the same acceleration, well, be happy and use your car for the purpose it has. That's it. But I mean, if you are a car freak and you know everything in your car, it's up to you. Good. That's what I'm saying. And back to the beginning of our today's webinar, when we're speaking about case selection. some things that I told you, yes, you have the schemes, you have the, if you took the photos. If not, I can send it to you after the webinar. Just let the administrators know about that. But case selection, okay, you can do this. And remember about the learning curve in terms of motivation. So don't get upset. It takes some time. And also about the thing is that sometimes you can start simple, starting with these simple cases. Hopefully you will get enough patience and for the selection. Or like I told you, sometimes you can rush in. You can start with anything. I mean, it doesn't mean that you have to remember about your old patient for orthodontic and say, yeah, I will start with this one. No, I mean, just start with anything you have. That's another approach. But even here, the basic thing is to know your approach and to know your provider again. So because when you speaking about know your approach, it's of course more about clinical part. It's when you have this or that case. Okay, we were speaking about crowding. You know what to do. After the diagnostics, okay, here we need the proclination. Here I would go with IPR, for example. It will benefit with the dark triangles, something. We will expand, keeping in mind the buccal corridors. So it's more about diagnostics, about your approach. That's important. It's the first part, and it's in the first place. But also know your provider. And we are getting back to the idea is that with your confident work, you should be confident in the provider you choose. So make a smart choice. That's the second point, which is probably even, well, not more important, but as important as your clinical part. So probably, yeah, I was quite quick. I'm looking at the clock because again, we're time limited, and frankly, initially I was asked for 3 topics in one webinar, and I said no, I can't do this. Even now, with 2 topics, we were rather quick. And my basic idea is to share my knowledge and hopefully remembering myself back then when I started. I'm happy that today the situation is changing, and the most important change for me is the how the providers change. That's if I had this kind of opportunity back then when I started with AccuAligners, I think my learning curve would be much quicker. But okay, now you have this opportunity. So let me just stop screen sharing, and maybe it will take me to the chat. Oh, and you have some questions in there. Okay, I have a lot of yes and yes. I don't know. Maybe I was asking if it's treatable with aligners. Okay, some questions that I can answer. Let me just look through. Okay, so let me go with the with attachments. We have the questions one by one. Expansion with aligners. And the good question, is it absolute or tipping? Okay, so when we speak about, and actually it's a good one to speak about attachments here. Why? Because if you think about the expansion of, let's say, premolars and molars, which I put, remember in my form for the treatment plan, of course we can have the expansion just by aligners. It's the plastic that which goes from left to right, and it expands. But you have a very good point. We have the pressure points, let's say upper jaw palatally, and it's we can't say it's a clear or it's just tipping. It's a combination depending on the initial position of the teeth, because think if they are palatally tipped, of course when you expand you change the tipping mostly, but that's what you need. If they are not, let's say, palatally tipped and you want to expand, yes, at some point you have both the root movement, which is less, and the crown movement, which is more, like this. What we can do in this case? In this case, what I normally do, there are two things. You can ask to have additional buccal root torque. Yeah, so it's like, you understand what I'm saying, yeah? So you just, in the clean check, you ask the technician to let's say, overcorrect, let's say, with the buccal root torque. So in this case, you will have the tooth movement more bodily. Another thing that can help here is the appropriate attachment, so that it will also control the tipping of the tooth, because it creates the second force, the moment of force, so that you have think the same as with the incisors. When you move them palatally and you don't want them to tip, and you have the power reach here, so that you have like a more controlled bodily movement. The same here, but in the other plane. So yes, depending on the situation, you might need this tipping, then there is no problem. If you need more bodily expansion, think about compensating it with buccal root torque with attachments. There are all of different shapes of attachments. Probably I have answered this question, yeah, because I'm not speaking about the commercial side, which sometimes unfortunately happens, and when the companies come and say this one and only this one. No, think about physics. The role of attachment is to have the surface for pressure, okay? And in this case, in the last cases I showed, it's not the shape, because the shape is kind of universal. Okay, they came up to this shape after several I don't know, maybe years. You can correct me. How much did it take? I mean, with the tests, but about the placing of the attachments on and of the surface. So that's the role. About which extent distalization is possible and how to keep the distalized molar stable until we retract premolars and anterior. Wow, very good questions. I mean, very good in a way that it's what should come to your head when you start doing aligners and the more complex cases. It's a separate topic. We can speak, if you want, about distalization. I will mark it here, maybe one of our next meetings, because there are different approaches. I'm pretty sure that all of you know about the let's say 1 second, yeah, approach, 1-3 approach. Okay, when you move 2 teeth at the same time, when you move 3 teeth, or when you have en masse movement, depending, well, first depending on the distance that you need to move, and of course on the anchorage, because one of the things you can use is a TAD. Yeah, if it's more than let's say 2 millimeters distalizing, normally we will think about TADs, and actually both for first we can use the TADs for for the anchorage of the, let's say, starting with premolar or canine, so to anchor them and to help the aligner move the molars. And next stage, you can use this, let's say, the mini screw to anchor the molars once they are in the position. You can even have what do you call it, like not elastic. Yeah, you can have like the metal ligature to put it like a good unit, good anchor, not anchorage actually, but not for the tooth to move back, to mesialize. Yeah, I know I'm trying to show that with my fingers only, but hopefully I just shared some ideas. And if it is a question, I can come up later with some, with some photos also. Have the biting effect is okay in treatment for open bite how to contact in deep bite cases. Thank you. Okay, yes, speaking about aligners and vertical problems, again, at this point, and probably that's what you had in Sandra screenshot, which I showed, the very, if we speak about the surface, about the understanding is, of course, we speak about the molars, intrusion or extrusion, and the frontal teeth extrusion or intrusion, depending on what case we have. Of course, it's also about diagnostics and about the type of the growth of your patient. But the biting effect is what you are saying here, is the intrusion of molars that we don't want, right? Because we all know that when we bite, it's not like this. Yeah, it's not like this. It's like this. So I can show. Okay, we have the first contact on the posterior teeth, and that's why, and the occlusal surface is more there. That's why very often we come up with the patients with mild disocclusion in the end of the treatment because of the aligners, aligner wearing and these intrusion. There are different approaches, yeah, to do that. Again, we are speaking when we don't need it. One of the things, okay, we can start from the most difficult ones. It's like when you ask for additional button cuts for, let's say, last 3 aligners, and you use elastics for extrusion, for making the contacts better. You can use the refinement for that. Yeah, because when everything is done, you order the refinement, additional aligners, just to deal with this problem. The simple approach, again, if we speak about simplifying, again, it's just something I came through. You do nothing. You do nothing because if it's not a very long treatment time, usually the disocclusion, it just goes away after, let's say, 3-4 months after treatment. The teeth, they will naturally come in a better contact. Knowing that, you can also do thing, not the buttons, but just to cut the last 3 aligners behind the, let's say, premolars. So you have 3 molars, and they also have this effect, so that they make disocclusion go. Okay. What material is best for aligner sheet? So, okay, I think this is one of the doctors who wants to go into the details to know the characteristics. Frankly, I understand you. So, that's why some time ago with the company, I had my also folder with different types of plastic sheets for different kind of aligners. I was really surprised that, let's say, 1 layer. We have 2 layers, but it's not for aligners. 3 tri-layer, and I was surprised to learn that the tri-layer materials and aligners can be also different in a way. The layers come there, so you can go soft, hard, soft, or hard, soft, hard, and it have different effects. So if you ask for the aligner manufacturing for production, probably I'm not the one to give you the answer to this one. Yeah, for me as a doctor, and that's what we started our meeting today with, I have 2 concerns. Yeah, I have 2 concerns. The first one, okay, maybe the second one, is the comfort of the patient. Why I say the second one? Because normally we don't have a patient using different kind of materials. So it's, let's say, first couple of months, very rigid material, and then like very flexible. So he or she can compare and say, oh no, doctor, please give me another one that was more convenient. No, they don't say that normally, but of course, if it's convenient for the patient to wear, to fix, to put it off, the better for me. But the first thing, of course, is the results. Because the more flexible, let's put it simple, more flexible material, which is tri-layer material, which has a better shape memory, and which has, like I said in the beginning, constant light force, I know that the results will be better in terms of the movements that I want to have. Okay, so again, it's a separate topic. As you can see, I just imagine, I remember the graph we had when we were comparing different kinds of materials, and sometimes we had the materials with higher force levels, and we think, wow, that's good, because another one was lower force. But then we see that with this one, it goes like this very quickly, it goes slow, and the second one was a little, okay, sorry, I'm just trying to tell you everything I know without any things to illustrate apart from my fingers. On lighter note, you have put on fixed braces, and oh, that's good. That's good. I was waiting for that one. Every time I will even show you if you haven't noticed. Yeah, I'm now you're wearing braces. And if you allow me, I know we are out of time, and it's not the out of days topic, but I can share you because we will see each other more often. It's my, I hope most of you are orthodontists and you know what I'm talking about. It's my second time wearing braces. In between, I had aligners. And frankly, maybe you can consider me a little bit crazy. I didn't have any indications for either. So the first braces I had was the multi-loop. You know, multi-loop, when we had to the wire bending on every stage when we have the stainless steel wire. Why? Because I had my colleague, student, and she went to Austria, and she needed someone to practice. After that, when I had I had a little bit of crowding. That's all I had back then. I used aligners, of course. I was going to treat my patients with aligners, and I had my experience with aligners. Everything was perfect. So I was happy with this one. And again, it was me who treated myself, but I had my assistant to help me with aligner thing. And now it's my second time with braces. Again, why? Because I don't know if I can say that, but one of my colleagues, he found very cheap braces. Very cheap braces. I shouldn't say the brand. And he told me, let's try. I can't do that on my patients. So can you give me as your teeth for testing? I said, yeah, why not? Why not? And to make me even more crazy, we did the diagnostics back then. And he said, you know what? Actually, you have a mild deficiency of the upper jaw. We need to expand that. But maybe because of your multi-loop treatment back then, I had a lot of bone recession. So my buccal roots were out of the bone. So we did the SARPA. So because I wanted to help my colleague with the test and the braces, I went to surgeon and I had my jaw cut in two and I had an expander. So, but you asked me first, so I'm just answering. So that's why. So it's more for the science, let's say. Any tips for upright and majorly tipped mandibular molar with aligners? Okay, of course, a lot of tips to upright the tipped molar, and let it be the last question because we are actually getting out of the limits already. And again, it would be great to see the picture. The first that comes into my mind is, of course, if we're speaking about, let's say, the second molar, and we want to upright that, be sure you don't have the the third molar. Yeah, or you can't do this. And for the tipping, if you, for example, don't have the first molar in this situation and the second molar is tipped, again, depending on the angle, you can do that with a liner, because you saw that in the clean checks, and it's very obvious. You have like the pontic, or like the bridge, which is the material in between the teeth, which actually helps with the material to upright the teeth and to get the forces that you need for uprighting. Okay, I'm describing you different situations. I don't see yours. And of course, sometimes you can go like this with attachment. Sometimes you need a TAD for the better controlling. That's why, Dr. Sarah, it's important to see the case. But of course, everything can be done. Okay, so I think we...
Yeah, thanks, Dr. Artem, for...
If you don't stop me, yeah, I can go on.
This time, see, I didn't stop you this time.
Yeah, thanks.
Yeah, so it was good. Let a lot of things come out, and it was very nicely put. And I think so people must have benefited this. They can apply this with their aligners, and if they're interested to work with us, we will be ready. And I've just put one, poll for a next topic, which is just integrating TADs with clear aligner therapy. So let's see if people are interested. We can keep that in the pipeline. Not will be the next one, but it will be there for the coming topics.
That's good.
And we will be arranging something, much more interactive in Dubai in a few months' time. And we will be seeing people who are interested to come down here can, contact us through email. And we already have your email, so you can have a replay of this webinar also, have a look. And, if you have any more questions, we will forward more questions to Dr. Artem. And he might, if he had time, he can answer. So let's wrap this up. Do you want to close, Dr. Artem, for the final?
Yeah. I mean, I'm happy that you said about one of the next topics with TADs. And it's funny how we go from case selection today to the next topics of TADs. Yeah, it should be a very quick learning curve for some of the doctors. But really, so speaking about today's topic, and to give you some final thoughts, is that firstly, don't be afraid to start if you are here for the case selection topic. Okay, don't be afraid to start. It's not that difficult, especially now when you have such partners and providers as AccuAligner, for example. That's good. And the second one, we were speaking about some details. I'm happy that you are interested, and I personally think that there should be a balance. I told you about two types of doctors: those who don't care about what they have on the clean check, and those who want to understand everything. I think it's very nice to be somewhere in balance and to know how it works, but don't have to think much about that. So I just wish you to have this kind of practice when you have great results, when you are satisfied. You and your patients are happy, and that when you love your work. And I hope AccuAligners will help you a lot with this kind of approach. Thank you so much.
Thank you. Bye-bye.
Bye-bye, everyone.